The disclosures for guests on this podcast can be found in the show notes.
Hello everyone and welcome to our 2026 ASCO annual meeting series where we cover some of the top JCO papers published simultaneously with their abstract presentation at this year's meeting. I am your host Yuvanesh Vendaraju, JCO Editorial Fellow, and I am joined by JCO Senior Deputy Editor Dr. Kathy Miller. In this episode, we will discuss the Journal of Clinical Oncology article and abstract presentation, Low-Dose Tamoxifen in Non-Invasive Breast Neoplasia, long-term results from an individual participant data pooled analysis by Densi et al. First, let's start with the relevance of the article. Dr. Miller, can you please explain the clinical context of this article and why this question is important for our listeners?
So this is really a question of access to and acceptance of chemo prevention. We've identified many risk factors that can help us select women who are at higher than average risk of developing breast cancer. And we have robust data from randomized trials using standard dose tamoxifen, standard dose aromatase inhibitors of postmenopausal women that they substantially reduce their risk. And despite having that data for almost 2 decades now, only 5% or less of women who would be eligible for chemo prevention accept those therapies or are even offered those therapies. There are many reasons for that. And I have always thought that in oncology, we made this too difficult. Our cardiologists made cardiology prevention, heart attack and stroke prevention, the bread and butter of internal medicine. And we have clung tightly to cancer prevention in the oncology arena, and that itself puts barriers. But we're also talking about using medicines that are used to treat cancer. And that can feel scary to our primary care colleagues. It can feel scary and toxic to our patients. And particularly for full-dose tamoxifen, the potential toxicities of hot flashes, the small but real increased risk in thromboembolic disease, the tiny but not zero increased risk of endometrial cancers can be real barriers for patients being offered or accepting chemo prevention. And that really was why Dr. Decenzi and several others started looking at would a lower dose of tamoxifen also reduce risk and reduce side effects and perhaps have a better balance of benefit and risk so that this really effective preventative therapy could be acceptable and available to many more patients.
Thanks, that's a great summary. So what are the key results and how is it different from the studies mentioned in the paper?
This is a meta-analysis of 3 individual trials. And like many meta-analysis, it brings the power of numbers to allow us to look at subset questions that are important that individual studies could do. So 3 randomized trials, randomizing patients at risk to either low-dose tamoxifen, that could either be 5 milligrams a day or 10 milligrams every other day. The trials differed in the risk women they identified. Some included patients with DCIS. Some only included patients with LCIS or atypical hyperplasia. One of the trials allowed patients with microinvasive disease, T1A lesions, to also enroll. They also differed in the age of the women that they enrolled. So for this combined meta-analysis, they got the individual patient updated data. So this was not just pulling together published reports. That gave them a little over 1,500 women, which allowed them to look at whether there were differences in the efficacy of low-dose tamoxifen based on what made you at higher risk, based on age and menopausal status, and whether they focused only on risk in the ipsilateral breast, the breast that had the initial pathology, or whether they looked at contralateral disease. Those are important nuances that I think are interesting to help us ponder the biology and how drugs might work. But I think other than the menopausal status, they're probably less relevant for the main message, which is that particularly for postmenopausal women, low-dose tamoxifen substantially reduced the risk of a new breast cancer diagnosis over now almost 10 years of follow-up.
Can you comment on the major strengths and limitations of this study?
So I think its major strengths really are in the number of patients, just over 1,500 patients in total. About half of those patients were premenopausal, about half were postmenopausal. And the individual trials randomized those patients to either low-dose tamoxifen or follow-up only, but no individual therapy. And I think that brings us to a weakness in this study that many will point out, that this did not directly compare low-dose tamoxifen to full-dose tamoxifen. It didn't compare low-dose tamoxifen to an aromatase inhibitor in those postmenopausal women. But the reason for that, and the investigators would point out, these were women who had been offered standard therapy and they declined. So the important comparison for the majority of patients who wouldn't accept our currently available therapies is this as good as full dose tamoxifen? It's really, does low dose have any benefit? Because if it has benefit, even if it's slightly less, if it's less benefit than something you wouldn't accept, I'm not sure that's going to make you accept the higher dose therapy just because it might be a tiny bit better.
So what are the main outstanding questions that still needs to be answered?
So I think the biggest question is really for our premenopausal women. In this large meta-analysis in postmenopausal women, the reduction in risk, the hazard ratio was 0.5. So it reduced the likelihood of a new breast cancer event by 50%. That was a 10-year absolute reduction of 11%. So really effective prevention therapy. But in the premenopausal women, there really was not a significant reduction. The hazard ratio 0.9, confidence intervals of widely crossing 1. Now, for the premenopausal women, interestingly, if they focused just on contralateral disease, the hazard ratio was 0.45, which really makes you wonder if for our patients with DCIS, which was the majority of patients in the premenopausal group, if ipsilateral breast really is treating microscopic residual disease that was not removed with surgery, might not have been eradicated with radiation. And the contralateral breast is really telling you about pure prevention, intervention at an earlier stage in the carcinogenic process. Now, that's a hypothesis based on these data, and I'm sure it's one that we will try to study in future trials and with our laboratory colleagues. But that is at least a hypothesis that is consistent with the data. I think what this tells us is that for premenopausal women, if they are interested in chemoprevention and they would accept chemoprevention, particularly if they've had breast conserving surgery for DCIS, that full dose tamoxifen is still going to be their best option. But it may still open the door for low dose tamoxifen in those patients who were diagnosed with LCIS or atypical hyperplasia as premenopausal women. I think they are probably best served still by full dose tamoxifen, but if that's not acceptable or the toxicities are prohibitive, then low dose tamoxifen may still be a consideration for them. For the postmenopausal women, however, it's really, I think, difficult to not offer patients low dose tamoxifen in that prevention setting with these confirmatory data and long-term follow-up.
So how do you think these findings may impact clinical practice or the future research?
I hope, and I know the authors hope, that these data will make chemoprevention a more acceptable, accessible option for many more of our patients at risk. I still think we might do an even better job of reaching into the primary care community, into the internal medicine, the family practice clinics, the GYN clinics, where many women are receiving their primary care, and helping those people think about low-dose tamoxifen as a chemoprevention option with substantial benefit and very little toxicity. There is only one tricky part, in that tamoxifen doesn't come in 5 milligram tablets. So that's why the studies looked at either 5 milligrams a day, which requires you to take the 10 milligram tablets and chop them in half. They're not scored, so you can't easily break them, but they cut quite easily with a pill cutter. Or the alternate, which was used in one of the trials, to use 10 milligrams every other day. I've been offering low-dose tamoxifen to my patients at risk, particularly the postmenopausal women, for a few years now. And it's sort of an even split. There are some who find it easier to cut the tablets in half and remember to take one a day. who would say try to keep track of every other day just seems more difficult. But both of those, given the long half-life, really give you very equivalent benefit and equivalent drug exposure.
Thank you very much, Dr. Miller, for speaking about the JCO article, Low-Dose Tamoxifen in Non-Invasive Breast Neoplasia, Long-Term Results from an Individual Participant Data-Pooled Analysis. Join us again for the latest JCO simultaneous publications presented at ASCO Annual Meeting 2026. Please take a moment to rate, review, and subscribe to all ASCO podcast shows at asco.org/podcast. Until then, enjoy the rest of ASCO 2026. Thank you very much.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.